Awesome. Welcome, everyone, and thank you for joining PARC's Disease Task Team webinar, Another Fungal Disease in Reptiles, the evolving story of Emydomyces causing shell erosive lesions in turtles. My name is Jenna Palmisano. I am the chair of the National Disease Task Team and a PhD candidate in Dr. Anna Savage's lab at the University of Central Florida. We are pleased to kick off today's webinar, and our goal with the webinar series is to help connect science and management action by providing information to land and natural resource managers. And so we welcome any input or feedback you might have. So before we begin, we have some general housekeeping notes. Live captioning is available if you click the CC button at the bottom of your screen. And the webinar is being recorded and it will be posted to the PARC YouTube channel later once we update the captions. All attendees are muted during the presentation, but you can submit any questions that you have at any time via the chat, and we'll address them during the Q&A at the end. We have people monitoring the chat, so don't worry, we won't miss your questions. On behalf of PARC, we'd like to thank the members of the Disease Task Team for coordinating the webinar and developing many resources to improve the awareness of disease threats to amphibians and reptiles, including disease-specific fact sheets, which are available on our website, which I think, Kobe, if you could link that in the chat, that would be great. And a special thanks to our speakers for sharing their time and expertise with us. So with that, I'm pleased to introduce today's speakers. First up, we have Dr. Matt Allender, who received his DVM and PhD at the University of Illinois. He now directs the Wildlife Epidemiology Lab, a collaborative research lab describing infectious and non-infectious diseases of reptiles and amphibians. The lab is a leader on snake fungal disease, as well as ranavirus and chelonians. Then we have Dr. Karen Theriault, who received her DVM from Tufts University and earned her PhD from the University of California, Davis, where she also completed a residency in anatomic pathology. She is currently a professor at the University of Illinois College of Veterinary Medicine Zoological Pathology program, and her lab here was the first to describe Emydomyces infections in chelonians. Forgot to switch the slide. Okay, there you go. Dr. Krista Keller is our third speaker today, and she is an associate professor of clinical zoological companion animal medicine and surgery at UC Davis School of Veterinary Medicine. As a clinician, she treats a wide variety of zoological species with a soft spot for reptiles, and her research focuses on the epidemiological triad of fungal infections in reptile patients. So welcome, speakers. Thank you for your time and sharing your expertise with us. I'll go ahead and stop sharing. And Dr. Allender, you can go ahead and start sharing your screen.
Great. All right, Krista, you're up first.
Hey, welcome everyone. Thanks for coming out and talking about some fungus in turtles. It couldn't make the three of us speakers any happier, so we can move forward, Matt. Just a little bit of what we're going to go through in terms of content, but I'm going to get the ball rolling. Dr. Allender will take over from there. Oh no, Dr. Theriault will take over from there, and then Dr. Allender will pull us through the finish line. But we're really going to try to be very comprehensive in what is known about this fungus and how it relates to host or turtle health. And next slide, Matt. Okay, so a quick introduction. We're going to first dive into who is this microbe. And this microbe is a fungus, but of course, kingdom fungi is a gigantic group of organisms. The lower down classification is going to be the taxonomic order Onogenales. And even if the word Onogenales is not on the tip of your tongue and something that you talk about day to day, what I'll tell you is that you probably could identify, or if you heard some of the other fungi that are in this order Onogenales, you would recognize them, because order Onogenales are going to be the fungi that have a lot of proteases in them. These proteases allow the fungi in order to invade live tissue. So these are our animal pathogens and these are our plant pathogens. And Emydomyces, who we're talking about today, is one of those that has proteases. And actually, all the ones we're going to talk about on this slide, here's a couple of genera of really important onogenalian fungi that infect and affect reptiles. They all have specific proteases of keratinases. So all of them are going to cause this dermatomycosis, where they start by infecting the skin. And in some of them, we've documented more systemic spread from that initial skin infection. Go ahead, next slide, Matt. The first and probably most studied of the onogenalian reptile fungi that all have these keratinases is going to be Emydomyces. The cause of Emydomycosis, what we've previously called snake fungal disease, is kind of our general term. This is a big problem for snakes in North America. So if you are working with reptiles in North America, you have likely talked about snake fungal disease and Emydomyces. Similar to the rest of these pathogens, it causes an initial dermatomycosis that can be super mild to much more severe. And in some cases, it is causing population declines, and in some individual animals going to a systemic or going deeper than the skin mycosis. I'm ready for the next slide, Matt. Emydomyces is my favorite fungus of the group because I do a lot of bearded dragon health in the companion animal sector. This is the cause of, again, yellow fungus disease or Emydomycosis. Emydomyces is the one of this group. So this genus has multiple different species that affect different lizards and snakes, and has been reported in turtles as well. But again, it starts as a dermatomycosis. Here is this bearded dragon with this ugly, gnarly looking area on its chin, and this can spread to deeper infection in these guys as well. Next slide. Paranisiopsis is probably the least studied of the group. We know it is a prominent feature in tentacled snakes under human care in North America. And we've seen, it's rising in different populations, and we've seen it as a conservation threat in a couple of small populations, but is probably the one that we know the least about is Paranisiopsis. Next slide. And that brings us to Emydomyces, who we're going to talk about today. So right now, there is a single species, which is Emydomyces testavorans. This was Latin breakdown is going to be devourer of freshwater turtles. And once you start talking about some of the clinical signs, you can see how it does eat away at the shell, usually, of these turtles. Initially described by Woodburn et al. So that was Dr. Terrio's, one of Dr. Terrio's PhD students. Kudos to them for identifying this. So it was a 2019 paper. And here's the phylogenetic tree, just showing some of the relationships between Emydomyces and some of those other onogenalian fungal genera that we just chatted about real quick. We also have some sequence information out there published that's down below with the strain type for Emydomyces that was first identified. But I think Dr. Terrio will talk a little bit more. Even though we talk about this as 2019, it was discovered in 2019, it was reported, but of course from cases that preceded that 2019 date by I think a couple of decades. And I'll have Dr. Terrio expand on that a little bit more. Next slide. So growth characteristics, this is something that can sound a little bit esoteric at times, like, oh, how does it grow? Where does it grow? And this is important for working with these microbes in the lab, but they can also bring some really important information towards understanding potential therapeutic targets, as well as understanding a little bit more about, the ecological niche of this of a microbe. So temperatures are really important with fungal growth. We have looked at between 7 and 30, and you can see here with that growth line, Emydomyces doesn't have a super strong growth pattern. It's not a super fast grower like my favorite, Emydomyces garoi, which grows out bananas. But we do know that it can grow at lots of different temperatures. And this is very similar to where our hosts live, where those turtles live at lots of different temperatures. We also know that even though it doesn't grow at some of our temperature extremes at 7 and 44, it's still, at the growth extreme of 7 degrees, it's still viable even after being exposed to that low temperature. So overall, it's a pretty hardy and pretty general grower at different temperatures. Next slide. We also know it can grow at multiple pH ranges. So it's not, a specialist that just like acidic soil or something. It really is more general and can live at a bunch of different alkaline and acidic environments. Next slide. It is salt tolerant, similar to many of the other onogenalian fungi in this group, which stinks because it would be really nice to be able to throw some NaCl at it and it dies, but that's not going to be the case since it seems pretty salt tolerant. Next slide. What we do know about it is pretty unique is that it has a pretty moderate water requirement. And so this could be a therapeutic target in some cases where desiccation is probably going to play a role in eradicating it from an environment, not from our hosts, but pretty unique about this microbe. And then again, it's a generalist. It likes multiple different carbon and nitrogen sources. It can tolerate sulfur compounds, and this general capability for it to grow in a large variety of environments indicates it's likely this commensal in moist environments that our hosts are living in. Next slide. So let's move on to some clinical signs. What sort of things that you would be seeing in your turtle patients would make you think that maybe Emydomyces is playing a role? Well, the classic presentation are going to be shell lesions. That doesn't mean that it's a very specific shell lesion that you should expect to see with your eyes. Over here, you can see some keratin bleaching. I like to call this depigmentation, but discoloration of the keratin. In the center, you can see sometimes the keratin is lost and we can see some underlying ulcerative, kind of angry tissue underneath. We can also see these pits, and that may be a little bit hardest to see, but indentations in the shell that may be associated with Emydomyces. Unfortunately, none of these are pathognomonic for Emydomyces, meaning other environmental infectious agents can cause this same presentation. Next slide. What's really interesting is when we dive into some of the diagnostic criteria is that what we see with our eye is actually typically just the tip of the iceberg. So here in image A, you can see, hey, yeah, there's some keratin bleaching, some discoloration, but when we do a CT, and on CT, the bone is going to be white. So hopefully you can see in image B, on that CT, this animal is going to has loss of bone, these punched out lesions of bone, because what we see with our eyes is the tip of the iceberg. What's happening underneath the keratin or deep to the keratin is that bone is getting eaten away. And we can see that in E and F, where now we have kind of cross-sectional, where the top of the turtle is up and the bottom of the turtle is down. And we see these areas of lysis. And over on F, we can see that this is because we have expansion of some of the bone with these keratin inclusion cysts that Dr. Terrio is going to talk a little bit more about. Next slide. That's not to say that all of our turtle patients that are infected are going to have the classic shell lesions. Some of them are going to have more of a dermal skin presentation. So alligator snapping turtles, which are a unique, fun chelonian species, but have a little bit of different keratinization. They have a lot more alpha keratin, which is softer and more flexible and pliable, rather than the brittle keratin that we expect on chelonian shells. So in alligator snapping turtles, we see a lot more nail loss, nail infection or paronychia. Next slide. Here we can also see snapping, alligator snapping turtles, where we see discoloration, ulceration, so this is a really different presentation, but this is also caused by Emydomyces, again, attacking keratinized structures of chelonians. Next slide. And that dermal presentation is not just in alligator snapping turtles. Here is a normal, beautiful Blandings on one side and one that is Emydomyces positive. And hopefully you can see not just the shell has some change in pigmentation, but also the skin looks very abnormal, discolored as well. And so we can see a bit of that dermal influence. And I would say this is more in the heavily aquatic species rather in the in and out of water species sort of thing. So important to think about that classic presentation on the shell, but definitely some dermal lesions as well. Next slide. And And then here is a beautiful image of an alligator snappling turtle. And sometimes we don't see the ulceration. Sometimes we see something more like hyperkeratosis, which is going to be, actually the skin thickening. We can also see disinfection, which is the skin is not shedding off properly as well. So although we're thinking about skin, really it's shell lesions. And then in a couple subset, we're thinking a bit about skin lesions as well. And now I will pass it off to my colleagues.
Great, thanks so much for that intro, Krista. So the next slide, please. So, as noted, like the predominant lesion that we first started seeing this in was in shells. And the northwestern pond turtles have been a population that we've been now monitoring for a number of years where they've had shell disease. And you can see that this is a 13-year progression of the disease in this case. And from A towards to D there, you can see that there's quite severe disease in D, but it really does start, we start to see it with that hyperkeratosis, maybe the depigmentation or bleaching lesions. Then you might start to see some pitting and roughening, or you might notice, like as in C, that shell's starting to look very dull. And then you get the deeper inclusion cysts and lesions like that. The next slide, please. In the pond turtles, we've also been looking at CT scans because they get these very severe inclusion cyst lesions. We're able to follow those using CT scans. I'll talk about the utility of CT scans later in a bit. But in this population, it's really been useful for monitoring disease progression over time. And we can see that over time. And so here on the left, you've got the same turtle and two successive CT scans. You can see the increased areas of bone lucency or bone loss in those CT scans over time in comparison to the first one. And if we look at that as a percentage of change of area over time, so we essentially utilize a program to calculate the area of bone loss, that area of bone loss increases over time, and we can see that from scan to scan over time within that population. Next. Similarly, we have started to see progression in Blanding's turtles here in Illinois, and where you can see progression over time in the same turtle and looking at from lesions on the left to lesions on the right. So just greater extensive area, more deeper lesions, deeper pitting, deeper shell loss that happens over time. But it should be noted that these lesions do progress fairly slowly over time. So it's not a rapid progression, but we do get worried when we start to see populations that have Emydomyces within it, because as we will talk about later, it's hard to get rid of once you've got it. And so we're trying to sort of see what sort of progression over time that we've got within these animals. It is slow, but it does continually progress, and it's really hard once you have an infection to sort of get rid of it. Next. The lesions that we see as well at the time of necropsy as a pathologist, and these were some of the lesions that we first started seeing that were unusual to us, that looked a little bit different than the classic shell disease. And that is these big sort of nodules that you can see that we could see protruding into the coelomic cavity. So you can see on the top there, and number one, that is the inside of the carapace of a turtle, and you can see all of those nodules protruding in. And in number two on the bottom, those are cross sections of turtle shells where you can see those large nodules. Some of them don't look like they communicate with the surface, but you can see they're on the bottom that usually you just have to find that perfect spot where that lesion does communicate with the surface. And these will be these big invaginations of the epithelium, the surface epithelium, and you'll see that on a histoslide coming up. And then they create these big nodules and inclusion cysts. As Dr. Keller pointed out, hyperkeratosis is one of the lesions that we can see sometimes in these turtles, but also squamous metaplasia, which is a very specific, it's a pathology term, right, that we use for, and that's a very common lesion that we see when any sort of skin type surface or epithelial surface is irritated. There can be inflammation. It's typically pretty minor in these turtles. There is loss of bone, so osteonecrosis. So that's creating those sort of those areas, those gaps in the bone. and then these inclusion cysts. But again, none of these are pathognomonic for Emydomyces infection, and all of them can be seen in other infections. The epithelial inclusion cysts are if you have those in a histologic, in a biopsy of a shell lesion, you need to be very suspicious of Emydomyces because it's often associated with Emydomyces, but not always. Next. So this is histologically, this is my bread and butter, is looking at these under the microscope. In number 3, that is what a normal shell looks like on histology. And so you've got the keratin along the surface. There is a very thin dermis underneath that, and then it's bone, right? So this is obviously what's, the protective portion of the shell. In number 4, hopefully you can see that that looks very different than 3. And you've got all of the cysts that essentially they communicate with the surface, but they're very sort of branching and multilocular. So some of what you see are the cysts that are down in the bottom are probably cross sections of a branch off of another area of a cyst. And then when we look at them in higher magnification, as in 5, you've got a cyst that's lined by a squamous epithelium with lots of keratin building up in there. And then there's actually bone in the center there that's dead. So dead bone within that. And that's sort of that dead bone that we're losing from the shell. So these cysts kind of, they go through, they go into that shell wall, and they're killing the bone, and it's getting sort of enveloped by these cystic structures. As was pointed out, these fungi are onogenalian fungi. They are keratinophilic. They like keratin. They utilize keratin as a growth substrate. So it makes sense that in these cysts, there's some crosstalk between the fungus and the host, and we don't know exactly how that's going on yet. But these cysts are essentially producing extra keratin than should be, that usually isn't there. And that is probably what's sort of fueling this fungus to be able to survive in these lesions. And in that number 6, you can see that's a silver stain for fungus, and all of those black branching things, that's all the fungus within those lesions. When we go to try to diagnose this disease, there are multiple different options for it. So obviously, when you think about fungal diseases, so culture is usually a mainstay of diagnosis for many things, but we can also look at histopathology like we just looked at it. Molecular diagnostics, so PCR-based tests, are really important for this disease. And then we'll also talk about imaging and CT and radiographs. So next. So culture. This fungus is very difficult to culture. Even once we have a culture growing, as you saw from some of those growth curves earlier, it grows very slowly in comparison to other fungi. It's very frustrating and difficult to work with. We had a very hard time, even though we could see the fungus in the lesions, and we knew it was there, and we were able to actually even get sequence on it. We knew that it was slightly different than the other onogenalian fungi. It took us a long time to culture it. And actually the key was, what you can see here is we took scutes from turtles and ground them up and put them into the culture media. It likes keratin. And then all of a sudden we were able to get the fungus to grow, because it would sort of grow right around those areas with the keratin in it. And so it's very difficult to culture. It can be done, but it's not easy. And so it's very difficult. So culture is really not a great diagnostic modality for this fungus. The histopathology is great in that we can see the lesion that is associated with it, and we can identify a fungus within there. But all I can tell you by looking at that fungus is that it's morphologically consistent with Emydomyces, but that doesn't necessarily mean that it is Emydomyces. We know that many of these turtles, especially if they're in the wild, but also even in managed care settings and in pets, there's gonna be fungus in their environment. They're aquatic turtles. There is going to be fungus there, especially along the surface. And so identifying that the fungus that we see is Emydomyces versus something else that's from the environment could be difficult. Molecular diagnostics are the mainstay for us for diagnosis of this, and I'm spending quite a bit of time on this. The one thing that's really important to note, and you'll see here on this slide and on the next slide, remember that they've got these big, deep cystic structures that are extending from the surface. So that arrow is pointing at the keratin, the surface of the shell. But most of that lesion is well below that surface of the shell. And I think on the next slide, Matt's got a little bit more. Yeah. And so, and here is those silver stains highlighting the fungus. So you can see that if you ran a swab across the surface up there, you're missing the fungus that's in that red circle. You're not going to get it. It's going to be, you'll get a false negative, in other words. And even in the cysts that open to the surface, those fungi, that black staining is much deeper than on that surface. If you have lesions that are like the pitting lesions that appear to be open to the surface, if you can take and sort of with a scalpel blade, sort of curette out that material, sort of scoop out the material that's in those pitted areas, that's really useful for us for diagnosis. Next. And then radiographs and CTs you can utilize, we have diagnosed cases that way. Again, just seeing bone loss is not diagnostic for Emydomyces, but it can be helpful for confirming that you do have associated lesions. And I think, is that a video, Matt? Yeah, there we go. So you can see in this one, you can see the multiple areas of bone loss within that shell. CTs are much better for diagnosing this than radiographs. The problem with radiographs is obviously you've got that superimposition of other structures on top of it, but at least on the CTs we can see this, and it's helpful for us to also identify exactly where those areas of bone loss and those cysts are, so we can target it for additional diagnostics. Next. We had an unfortunate opportunity recently to look at diagnostic performance of some of these different tests in a group of 90 Blandings turtles that were within a Head Start program. And so what we did was these animals had a number of different diagnostics performed on them, and we were able to compare them, compare the diagnostic performance of these different tests on the left with utilizing some statistical modeling and latent class models. When we looked at, a couple of different things. All of these turtles were within tanks that had water that was positive for Emydomyces, which you'll see in a second. Yep, there we go. So here you can see that they've got the water samples for the turtles were all positive for Emydomyces and this is by qPCR. We looked at swabs of the shell, the cloacal, oral cloacal swabs, oral cloacal shell swabs, and then CT scans and physical exams. And as you can see here, that the numbers of animals that were tested and that were positive in the different groups. And I think we've got some additional coming up. So this is those statistical tests where they're looking at agreement between the different testing results. And then here's kind of what you need to know. Those cloacal oral shell swabs had the highest sensitivity and specificity overall, and is the one that we would recommend for antemortem surveillance. If you are in a situation like we were, where you really don't want a false negative, right? There's a high cost for a false negative because we don't want to be releasing a Head Start turtle that is positive into the wild. You can do 2 cloacal oral shell swabs in parallel to increase that sensitivity and specificity. Water samples, I think that's the next, is also really useful for group testing. And so we typically will take 500 mils of water from and this is most useful in a managed care setting, so from a tank, and you can we'll run that through a filter and then test the water sample. And that's really useful for screening a group of animals, at least to be able to know whether or not we've got Emydomyces in that environment or not. As you will see, the CT scans were not useful, particularly. Many of these animals, these were Head Start animals, they were small. And so that may have contributed to some of the lack of sensitivity for this diagnostic. in this group of turtles. We certainly have utilized it with a lot of success with the northwestern pond turtles, but they tend to have more advanced disease than these head starts did. So I think that if you're going to utilize CT scans, it needs to be an adjunct, and it certainly is going to be something that's going to be more useful if you have animals with more advanced disease to sort of monitor disease progression over time. And I think that the last of mine, Matt. Yep.
All right. So I'm up. Thanks, everybody. All right, so we're gonna move right into epidemiology, and I would classify this that we're largely uncharacterized um, uh, over the course of a lot of wild studies. The detections in wild turtles have historically come from Washington and the northwestern pond turtle. That's well documented by Katie Heyman and her group. California, we found it in red-eared sliders, which are an invasive species there. Illinois, we found it in both a pseudo managed care Blanding's turtle population and in wild invasive red-eared sliders, and then in Florida in a cooter. What's unique about this compared to Emydomyces, which is ubiquitous in every environment in North America, is that Emydomyces is not ubiquitous in wild populations, but it is ubiquitous in managed care settings throughout all of North America. At least what we found in testing of lots of different places. And to highlight that, we did a project looking at about 1,000 turtles in Illinois of 6 different species. We've expanded this to include eight species and now 4,000 turtles over the course of the last 6 years. And it really isn't in the wild in Illinois. We have it in managed care settings, certainly, but we don't have it in the wild. Blanding's turtles, that was kind of a pseudo-managed outdoor area. And then the red-eared sliders have been pretty rare, even though that we detected it. It's been pretty rare. And in the last 2 years, we've tested over 2,400 turtles in just the Chicagoland region, and we haven't had a single detection from any of those wild turtles. So it really isn't in the wild here, like it is in the wild in Washington. So again, something completely different than what we're seeing with Emydomyces, where, when we're talking about Head Start programs, we're talking about releases or translocations. With snakes, you're probably going from an Emydomyces positive site to another Emydomyces positive site. With Emydomyces, we're not there. Luckily, most of these populations don't have it. But what have been the detections? The detections are pretty broad. Every species that we, really taxa that we work with is susceptible. The ones in red are the wild species. The ones in green are both wild and captive, and then the ones in blue are mainly just captive for now. But these are fluid, right? Karen and I commonly get samples and we'll go out and do surveillance, and we'll find it in places that we don't. So I would just consider every aquatic species susceptible, and that would be where I would say most of our positives have come from. But as you can see there, the gopher tortoise has been detected, and we have been doing a lot of gopher tortoise surveillance lately, and the prevalence is higher in gopher tortoises than it is in many of our Blanding's turtle populations. So it is certainly in the wild, and it comes back to, a little bit to some of that phylogenetic tree at the beginning. This is such a difficult organism to culture, and we are characterizing it based on a small segment of DNA from our PCR, that there is likely going to, we just don't know what the variability in the taxonomic range of this pathogen is, and if that leads to differences in disease or transmission or anything else. And I'm sure those comments and questions will possibly come up later. And that's going to highlight how little we know right now about the epidemiology as it relates even to the ecology of the fungus. So northwestern pond turtles, these occur from Washington to California, steep declines in the 90s. And recovery efforts have largely been successful, mainly because of head starting programs. Well, it's those exact same head starting programs that have caused population numbers to increase, that have introduced disease into wild populations, and is now causing threatening of those successful programs. Karen talked about it earlier, but the timeline of this is 2009. They first started seeing unusual shell disease in northwestern pond turtles, the lesions that Karen went into. 4 years later, they started to do surveillance, and lesion prevalence was between 29 and 49%. So that's pretty significant, right? And then CT scans a couple of years later showed bony lesion prevalence of 84%. And if you compare that to where we are with blandings in the Midwest, where the prevalence is less than 1% or at 0.6%, this disease had been going on a while. And because it occurs at such a protracted rate, where lesions really don't come up until 4 to 10 years after infection, it's easy to miss, and it's easy to overlook, right? I mean, 13 years, that's almost half of a career of some of our, of our work. And if you're looking at these animals and you're like, I've never seen this in my career, and this has never been a problem. I've watched these animals for 15 years. Well, honestly, if the infection had started the first day of your job, you might just start to be seeing some of those lesions halfway through your career. So I would say that makes the epidemiology very difficult. It also makes it difficult to identify the timeline of when these infections or introductions might actually have occurred. It also dictates the inability that we have to intervene maybe 8 years into it, and what we would expect our success rate to be if the disease has already progressed 60% of the way before we even knew it. So that leads right into treatment. So Karen mentioned earlier for diagnosis, and this is where we contradict ourselves in this, is in order to get better diagnosis, you have to get to the fungus. You have to know that it's there. You have to dig it out. But if the minute you dig it out, this lesion becomes worse. Lesion debridement is leading to inflammatory responses that are often causing spread of these pathogens throughout the body. So trying to get a diagnosis prior to having to dig it out would be ideal. From a long-term standpoint, which is why it's so interesting that the cloacal oral swabs or combinations fare so well in the sensitivity and specificity. It actually probably gives us a little bit of an opportunity not to debride to get a diagnosis and preserve some of our treatment efficacy. So antifungal therapy, MIC data was available from Karen and Dan's paper that showed all of the different fungi, all the different antifungals that you can see here in the bottom right that can be used, and what their MICs are for the different isolates. So we used 3 different isolates. And so antifungal therapy could have happened locally or systemic. The treatments have historically been oral or nebulization. And so in that unfortunate case where we had an outbreak in our Blandings turtle Head Start population, we had 343 out of 560 turtles in the Head Starts that were affected with this pathogen. And so we were able to break these animals, these 300 animals, up into really decent size, sample size for 7 different treatment groups. And actually we've added 3 more since this started, where we had environmental treatments such as increasing the salinity, UV filtration, salinity and UV, antifungal therapies, including terbinafine implants, nebulization or baths, combination, including implants and UV. We've also looked at bioencapsulation, which Krista and one of our former residents worked on. We've done brumation treatment, where we've, again, allowed, hopefully, a normal immune response to maybe do some of our work for us. And we've done this successfully in uninfected turtles, so we were going to give it a try. And then we've tried various different azole antifungals. I'm not going to go into the azoles. The azoles are terrible, especially in snapping turtles, alligator snapping turtles. We had mortality greater than 50% at therapeutic doses that are published in every species, and sometimes even lower therapeutic doses. So azoles, I just don't trust in these species. So we looked at these treatments for the first 12 months. We're now in month 37, so I have other data for that as well. Weekly weights, physical exams, every week, every 2 months, water samples using qPCR, and every 6 months, turtle swabs until they were negative. Then we were doing them monthly until we got 3 negatives in a row. And this was part of an adjunct project of one of my former PhD students, Caitlin Moorhead, who spearheaded this with our amazing biologists in Lake County Forest Preserve District, who executed the treatments on a daily basis, on a weekly basis. So it's been pretty monumental feat. So if we're talking about our shell discoloration or depigmentation or bleaching, however we want to call it, it's all the same thing, is the zero shell discoloration. These are changes over a 12-month period. The ones that had the best and the least shell discoloration over 12 months were the salinity and terbinafine bath. And you can see the controls, obviously, without treatment, their bleaching got significantly worse. But things like terbinafine implants really weren't any different than controls. UV sterilization of or filtration of the water alone, not very good. Nebulization really was kind of midway. I'll tell you that nebulization did nothing for the Emydomyces concentration, so it might have made the animals look a little bit better, but it did not. It did not treat the infection really. So, when we look at that, the change in Emydomyces quantity at 12 months, the terbinafine baths are the only one where the confidence interval didn't cross 0. Meaning it was clearly our best option to use. And when we look at all of the other data, in fact, the terbinafine implants, which is what everybody calls and wants to use these implants because they last 6 weeks, right? Like it's a microchip that goes under the skin, lasts 6 weeks. Well, they fared worse than the controls in these cases. And that's knowing the physiology of how Emydomyces works, that's not terribly surprising. We also confirmed this with cases in northwestern pond turtles that had come out, and we had tried it at the same time. So implants are not an option that we can recommend. So then after 12 months, what did we have as results? 87% of the turtles in the terbinafine bath group were qPCR negative. And when we say qPCR negative, that's not a single detection. It is 3 consecutive negatives that are separated by at least a month apart. And so 87% is pretty remarkable. In the 12 months after this number went up to about 93%. We've had some relapses that have been off treatment for a range of 6 to 9 months that end up coming positive. But in general, we have success rates of greater than 80 to 85% with the terbinafine bath, and we weren't seeing that with anything else. I never also saw that with Emydomyces. Especially in water snakes, they're pretty hard to treat for Emydomyces. Disconcerting. We knew it from our antemortem testing, but 100% of the turtles in every other group tested positive. And at necropsy, subsets of each of these groups had histologic lesions that Karen has discovered or discussed already, and they were successfully cultured from these animals. So it wasn't just qPCR positive and maybe remnant dead DNA that we had killed. These animals that were testing positive also had live fungus that was continuing to grow in the face of antifungal therapy. So then we moved into a phase 2 where all the remaining alive animals went into bath treatments with or without salt. Everybody had UV filtration put on them. And again, we were retesting and doing treatment until we got to negatives. And this is kind of how we designed our phase 2 treatment opportunistically, is that we had those original terbinafine bath where 26, right, were negative. We split those into terbinafine bath plus salinity, just terbinafine bath. The positives went into those same groups. And then all of our control turtles that we had left all went into terbinafine bath plus saline. And then the results after 12 more months of that is that 29 out of the 30 were negative after 15 months of treatment. We had 2 relapses, and these animals really did well. But what I'd like to say is that we have now seen, and again, we're well into this, is that there are some individuals that are hovering back and forth between positive, negative, and our level of detection on the qPCR, because it is so good, and I think the terbinafine is working. But those ones that fluctuate back and forth and can never really get to that positive do truly have infection. We might be holding it at bay, but when we euthanize and necropsy those animals, the infections are showing inclusion cysts. Not severe as if they were controls and untreated, but they still have lesions. So there's individual variation, just like we would expect with every other species on the planet, to treatment. And there is no 100% treatment, and some individuals will respond better than others. But in general, this has been quite successful. We have had the opportunity to opportunistically necropsy animals that have been negative for 9 to 12 months due to a range of issues or euthanasia or management things. And those animals have not been detected with Emydomyces or inclusion cysts in the limited number of cases that we've done. So that, again, reconfirms that the antemortem test so far has been equating to the postmortem results. And I don't think Karen and I expect that to be the case forever. I think there is going to be some cases where there's some false negatives and false positives, but we have not seen that if we're relating it to necropsy. And so the animals that were positive at 12 months, the control animals that we started on salinity and terbinafine bath, within 3 months, 7 out of the 30 were already negative. And so this combination, which we hadn't used in phase 1, because we hadn't necessarily thought about it, we combined the 2 best for phase 2, is actually working a lot quicker. So by 9 months, we had 90% success rate compared to the 12 months it took just for terbinafine bath alone. And those 3 positives fluctuated between positives until we euthanized them, and they had disease. Disinfection. So as biologists and veterinarians, we obviously care about doing no harm, especially when we're working in wild settings or when we're managing collections of animals. So what works? So we looked at lots of different disinfectants. Here's the list, and this paper is already out in Journal of Wildlife Diseases. Bleach at a couple of different concentrations for 1 and 5 minutes both worked. So you don't need to go 5 minutes. You can go 1 minute. Betadine, chlorhex. The caveat on chlorhex is that we've shown that it does not work for Emydomyces. So if you're looking for a broad spectrum disinfectant that works for all reptile species that you could encounter, chlorhexidine is not it, but it does. It is nice to be able to have that option for turtles. Rescue works, heat works. And then we're going to get back to one of the things Dr. Keller said earlier. Ineffective disinfectants included Virkon, which is unfortunate because that's what works well for the ranavirus. Ethanol, which also works well with ranavirus and with Emydomyces. The benzalkonium chlorides, and then desiccation. We said that this has a water requirement, and you'd hope that desiccation could work. But what we found was that it didn't. So we could take the fungi and dry it out for 24 hours. And then we plate it and it still grows. So dry docking, which I really dislike for most of our turtles, I feel like it actually makes life a lot worse. does not seem as appealing as it had initially when we're talking about this. Obviously, we know gopher tortoises aren't soaking either, so we know it can grow in the absence of water. But we did start a dry docking and terbinafine bath treatment trial that we're now into month 2 of with Blanding's turtles to see if we can get the 9 months it takes to get these guys negative down again even farther. Because the longer they're positive in a managed setting, the more they're shedding into the environment, potentially exposing other turtles. And in a wild setting, if we're missing an entire activity season, those animals are going to be less adapted to be able to be put back and less successful than if we can get them back in the same activity season. So things that are actively happening right now, Dr. Terrio and I are working on an infection trial to fulfill Koch's postulates with the type species, characterizing the epidemiology. We're continuing to do that, the morbidity and mortality studies across species, long-term treatment and efficacy data, which we're starting to be able to compile this after 3 years and put it out there. And then we're constantly trying to improve diagnostic strategies. So at that, we have enough time where we can answer questions for about 10 or 15 minutes. And we really appreciate all of your attendance. Thanks.
Thank you so much. We do have quite a bit of questions. I'm going to start with some of the first ones that were more, I think, management based. So one of the questions we have is there any evidence that shell notching used to mark individuals for mark recapture study could transfer the fungus between individuals and or increase vulnerability to infection?
Since I'm doing the most shell notching, I guess I'll probably take this one. That has been a question that we've had, and we have not altered our methods, partly because we're using what everybody is doing and what we've historically done as a natural experiment. The advantage that I have in Illinois is that we don't have Emydomyces in the wild, so I can't really tell you if it's transmitting. This would be certainly a discussion about northwestern pond turtles on whether or not they feel that that is possible. I would say good biosecurity in between turtles is paramount, no matter what you're doing, whether it's bone notching or not. I would say it seems reasonable that notching of the shells, if you didn't disinfect, could lead to transfer of the fungus. But I don't know what that risk is. And that's largely for a number of factors. But the number one thing is we still have not proven that Emydomyces is what's causing this disease. We know that all of these diseased turtles have Emydomyces with them. And I anticipate we are going to be able to induce it. And in a year or 18 months, we're going to say that Emydomyces is the cause of Emydomycosis. But as of right now, that's not the case. It's entirely possible that there are cofactors or co-pathogens that are driving the pathogenesis of this as much as the presence of Emydomyces. And until we know more about those things, it's hard to answer that question thoroughly.
I was going to say that it's something that we're hoping to look into as well with the Koch's postulate study, is that like with Emydomyces and Emydomyces species, are we looking at something where if there is damage or abrasions or scarification of the shell, that makes it easier for the fungus to sort of take hold? We don't know the answer to that yet. Yeah, and we haven't fulfilled Koch's postulates. We have a lot of data showing the very high statistical association of the lesions with the fungus, but we don't necessarily know exactly how it's causing the disease or if it's a sole cause.
Great, thank you so much for that detailed answer. We have a lot of questions, so just give me one moment to see where I should head to next. One of the questions kind of related to both head starting and captive questions is, is the presence of Emydomyces in managed care due to any identifiable causes? And do we know where it came from and why we're seeing it so much in captive turtles?
Well, I think we can Karen and I could probably give detailed answers on this one as well. But the end result is no to all of those questions. We don't know where it came from. We don't know what's happening. I would say, we all have opinions on this. I just, from an epidemiologist standpoint, the fact that the prevalence is orders of magnitude higher in managed care is not something we've seen with any of the other fungal diseases in wildlife. We have always seen higher prevalence in populations in the wild, and zoos and aquariums have outbreaks, certainly, and morbidity and mortality events, but not consistent higher prevalence. And this goes partly to the fact that this is such a hard disease to diagnose, and since it happens over such a long period of time, it was misdiagnosed probably for decades, and these animals were then transferred between zoos without biosecurity and without appropriate testing. And so I think through no fault of anybody's and through all fault of all of us, we got into this scenario. There are probably other diseases that we've also not gotten the diagnostic testing, to catch up to the disease. And in reptiles, I've seen this, right? We've seen this in our career with snake fungal disease where, oh, these are hibernation sores. These have always been there. They've never caused a problem. And it's like, well, okay, they're causing a problem now. And maybe they were before, maybe they weren't, but they are now. And Emydomyces, we've always had scud and citrobacter associated cutaneous shell lesion. Are some of those misdiagnosed from 30 years ago? Absolutely. No doubt. I have no doubt in my mind. And so were there missteps? Absolutely. But I would say we don't know where it came from. I would, again, unlike if we're comparing it to Emydomyces, which we know a lot more about, which, the current literature and current evidence supports that it originated in Southeast Asia. But it's been here on this continent for, 100 years. Emydomyces is not ubiquitous across the North America landscape. Like it's not been here. And, we need to do more surveillance to figure out, are there multiple species or strains of Emydomyces and how those might have evolved over time? Absolutely, to answer some of those questions. But I don't think that this is a North American native fungi.
Great.
And also
Thank
share, just in response to that question, that from a companion animal sector, I'm commonly presented with one very sick turtle in a household or from a small zoo that has clinical Emydomycosis with very clinical shell disease. There are 3 to 8 other turtles of the same species in the same environment that are also positive for Emydomyces, may have shell lesions, but those shell lesions are super mild. And when I look into the health status of these animals, the one who has the worst shell disease is often the most systemically ill for a totally different reason. So the one that I'm treating right now, we diagnosed her with hepatic fibrosis. And once we started getting that under control and was able to diagnose that, now she's making headway under treatment. And so I think we also need to think about that individual animal or population of animals host response as it relates to their disease manifestation when exposed to this fungus. And that there's a whole, right, like if you're under human care, your host immune response may not be as robust as if you are living in your normal natural environment. So.
Yeah, I'd also say we know that there is a lot of difference by species. So there are certain species of turtles that are very susceptible to developing disease with this fungus, and there are other species that seem to be more resistant. Now, whether that's truly resistant or it's just they're earlier in infection, it's really hard to tell. Like Matt says, like when it takes a decade to really develop full-blown disease, it's easy to see. That's a long time frame for us to study these things. But I would say that in my experience, certainly there's the northwestern pond turtles from the wild perspective, but in a managed care setting, I have seen very severe disease with mata-matas. Many of the Amazon River turtle species and stuff like that have been really badly affected by this. So.
Thank you. I actually have a question specifically about northwestern pond turtles. Is there any information on the age distribution of infection in that species?
I think so. It's a little bit difficult. So most of what we're looking at are adult animals. That population is really difficult to sort of look at from that perspective because many of those populations that we're looking at, many of those individuals came from a Head Start, so it's a little bit artificial. I think that we actually have, I think I saw Stephanie on here, and I don't know if you want to put something in the chat, if you know that the answer to that. But
I guess
I mean, it's fairly ubiquitous in some of those populations, the infection is fairly ubiquitous. So.
Gotcha. Well, a follow-up to that is another question, is for the organizations that do Head Starting, should they be thinking about doing or conducting turbinifying bath treatments as a precaution prior to release?
Testing.
Yep. Agreed. I would not treat. It's a microorganism that likely has the ability to develop resistance. And we don't want that because that's our one thing that's working right now. I would say, and I noticed a segue, Jen, I hope you don't mind in me combining this with another question about, is this a pathogen we should worry about? Is this a pathogen that we need to do surveillance for, or is this a pathogen just, for information? I will say there are only 2 pathogens in North American Chelonians that would prevent reintroduction or translocation if they tested positive. Ranavirus and Emydomyces are the 2, and for different reasons. But the same impact is that these are conservation level threats. Unlike other pathogens, which are individual level threats, things like mycoplasma, herpes viruses, adenoviruses, those types of things are important on an individual level basis. And you certainly don't want to, release new pathogens into an environment. But Emydomyces introduction into a population is going to have long-term conservation implications. Biosecurity protocols should be directed to make sure you're counteracting both of those pathogens, and testing prior to release or translocation needs to occur in susceptible species for Emydomyces. And I would say that there is a there is a large contingent of management agencies around the country that are already doing this now. So I think there's a lot of protocols that are available among our colleagues in order to do this. But Emydomyces, especially because it seems to be targeted around head starting, is incredibly important in those head starting to test. I would not release a positive Emydomyces.
Understood. Thank you. So I have a couple of questions based around susceptibility. And I know that a lot of this research is on the frontiers here. So I have a feeling we might not know the answers to these, but we're kind of wondering if there are any immune parameters identified that are related to susceptibility of infection. And also if there's evidence to suggest that climate change could be a contributing factor to progression or susceptibility to the disease.
Unknown on the immune function stuff. That will be one of the things that we will be looking at as we are infecting these turtles and trying to develop disease to see how those change over time. So we might be able to identify something from that, but we don't know yet. And then as far as climate change, I mean, yeah, I think that that's something that is probably in the back of everybody's minds with regards to why are we seeing this now? But then the bigger question, but it's also entirely possible Shells are not easy to look at histologically. They are very difficult. It takes, it's hard to get them decaled and in a way that you can see the lesions really well. And I think that many of us sort of just chalked these up to scud in the past. And it wasn't until we actually saw some of the nodules, extending in. And I think the very first case I saw it in was a mata actually. And that we actually did the hard work of sectioning the turtles shells to look at these cysts that we identified it. And then we kind of went back and we found cases that we'd missed it in. So I think it's really entirely possible we've missed it. And so climate change may be impacting it, but it may also just be that, we've as a, we've been caring more about looking into these shell diseases in turtles more recently. So.
Thanks so much, Karen. I guess another question we have is this particular fungus inefficient at invading the keratin of the mouth parts in these turtles? And is this related to the higher sensitivity of COS swabs?
I would say it's not inefficient at invading the mouth parts. I mean, the mouth parts don't have a lot of keratin like it would be like a tadpole or something. So, but I would say we bounce back and forth on why the COSSs, the oral cloacal shell swabs, are better. And I think it has something to do with both um, uh, analytical as much as ecological. I think in some of these animals, like it's infected animals in that we did this testing for on head starts. So they're drinking and eating and defecating all in that water. And so I think they're just exposed through passive swallowing on the mucous membranes. But so that's I think one of the reasons. I think analytically, if you look at the DNA concentration on a shell swab, it is so low. And what we know from PCR assays is that the more DNA that you can have in there, the better efficiency those assays run. And so it's a lot better to get more DNA, even if it's just carrier DNA from an oral cloacal swab, in order to help the PCR reaction function better and pick up some of those smaller concentrations. So I think there's a couple of different reasons. To my knowledge, and Karen, tell me if I'm wrong, but the histo on the oral lesions has not shown oral lesions. You're not seeing the fungus in the mucous membranes of those tissues.
Yeah, no, we haven't seen any oral lesions to date. The lesions that we've seen have been confined to the skin and the shell. Skin, nail, shell.
Lots of questions trickling in. We'll cut it off in 2 minutes here because our speakers have to go. But another question that we have is, have you seen any cases where you think that pollutants contribute to the progression of the disease?
No.
Okay, that was a quick one. Another question talking about more of disease outcomes. Does the interplay between existing illnesses and fungal infection play a role in how quickly the disease develops?
That is a good question and one that we are working on. I will say the preliminary information from the first few hundred turtles indicates no. Is that this is a primary pathogen similar to Emydomyces, where underlying diseases do not seem to be playing a role at all. Like, could they contribute? Yes, but that's not what we're seeing.
Another question is, you stated gopher tortoises are highly susceptible. Has it been introduced into wild gopher tortoise populations?
Yeah, these are repatriated gopher tortoises mainly. So it's a mix of wild and repatriated. Like gopher tortoises, I mean, are there any true wild that haven't been affected or introduced with repatriated animals. So it is in those populations.
All right, the last question I will ask is for the terbinafine bath treatments. There was kind of specific questions on the protocols. I don't know if there's a publication, Matt, that we can send people, or if there's just an upcoming manuscript that you are going to release soon.
Yeah, it's currently in some revisions, but it's 1 to 2 mg per mil bath solution. It doesn't, we crush tablets because that's the easiest and the most cost efficient way to do it. And it's what we did for the entire pharmacokinetic study, so we know it works. The animals are put into that bath for 30 minutes, 3 times a week. We have not tested fewer or more treatments. We tried to do the Goldilocks and right down the middle of what we thought was possible logistically. And you do it until you get 3 negative tests, qPCR tests separated by a month. So in general, it is usually no less than 9 months of treatment of that, and can be as much as 3 years, as we're seeing.
Okay, thank you so much. I'll cut off the questions there. Thank you again, speakers. I'm going to go ahead and stop recording.